So thanks, Rick. We're going to have a second talk. The second talk is entitled A Century of Evolving Pandemic and Emerging Diseases Challenges. So let me try to introduce Arnold. Professor Monto is the Thomas Francis Jr. Collegiate Professor of Public Health and Professor of Epidemiology at the University of Michigan School of Public Health in Ann Arbor. He's done a lot of stuff, and some of these are leading some of the fundamental studies in influenza, such as in other diseases, such as those done in Tecumseh. But to make it really simple, when I entered influenza, again, a few decades ago, Arnold was already clearly the senior epidemiologist for influenza in the world. And when I became the head of the epidemiology section at CDC, whenever we knew we were getting into trouble, we would basically say either, what would Arnold do? Or let's give him a call and find out what he's recommending that we should do. It's really with a fantastic amount of pleasure and deep respect for Arnold that I'm delighted that he's here to speak with us. Thanks, Arnold.
Thank you so much. Thank you so much, KG, and I won't go into the details of when in 2009 I got a phone call in late April, beginning May, about being on an emergency committee, which had interesting repercussions. I've got a very broad topic to deal with here, and what I thought I would do would be to concentrate on the thing I know best, and I think which is our biggest worry, and that's pandemic influenza, and to really identify some of the issues and some of the myths that have evolved with influenza over the years, and how this may, in fact, determine how we should respond, because a lot of these things, and KG mentioned before that we keep reinventing influenza, and I'm going to point out, as we go through influenza history, some of the things that have come out in the past which we've only recently re-identified. And if we really had a better idea of what went on in the past, we might better be able to be prepared for some of the things that shouldn't be surprises as we go forward. Now, having said I'm going to talk about influenza, I'm just going to take one diversion into coronaviruses because I think the response to SARS was a very good indication of how things should work out, but often haven't worked out, because here the SARS coronavirus, and mainly I'll take a parochial view of this and say mainly because influenza people were involved in the work on SARS, and the teams were already ready to go for pandemics, and the coronavirus was identified very quickly. Not that we had any real, other than non-pharmaceutical approaches for SARS, but things were identified pretty early, and we identified where transmission was taking place, and those from Hong Kong might recognize, I think this came from Malik Paris, and the transmission was very different from what was going on in influenza, and resulted in mainly nosocomial transmission, because people got into the hospital at a point when they were transmitting the most. And there was not a whole lot of community-level transmission, except in rare exceptions such as Amoy Gardens and things like that, where transmission might have been different. So the age distribution reflected that, and this is very important when we start thinking of where we're going to distribute interventions. We really need to know very quickly what the age distribution is going to be like, and what this coronavirus was very peculiar. It was hard to even show that young children were being infected using serologic studies and the rest, but it was mainly younger adults, and mainly because a lot of them were hospital or nursing home employees, sparing of the elderly, which is another issue we'll come back to. that's interesting. Oh, and this is the transmission. And this is the fact that airplanes were clearly involved. And we always come back with influenza. What about airplanes? This, again, is from Beijing and shows how SARS spread everywhere. The idea of super spreaders keeps coming up. I don't think we really know and have recognized super spreaders with influenza, but clearly it was the case with SARS. And this is another opportunity for non-pharmaceutical interventions and to just go up to date with MERS, which is like SARS, being a coronavirus, but very different in terms of the nosocomial host. SARS was contained in about 1 calendar year, but MERS is still with us, but we still have nosocomial transmission. The outbreak, this is from the Korean outbreak, and it was devastating because they weren't prepared, and they weren't prepared to recognize quickly and to contain quickly. So the outbreak took place over a fairly long period of time, but again was mainly associated with nosocomial transmission, and here super spreaders. So these things are important. Transmission is important, as are many other factors with some of the pandemic and epidemic threats. Now, this audience knows all about the history of influenza, and I just decided to roll out an old PowerPoint and put some of the older identifications on, which we first, until 1980, these were the names we gave to the various different kinds of influenza. I'm not going to go into original antigenic sin, which really was confined to the H1N, what we now call H1N1, but imprinting and all the rest have come back, and this was all out there in the past, and now with the work on universal vaccines, we're thinking about this all over again. But I'm going to start out with 1918, and these numbers are fairly, have not really changed in terms of the estimates of what of deaths associated in the U.S. But what's changed over the years with 1918 is the global estimates. And why is this the case? And this is from a Jordan textbook of influenza, and I'll show you some other contemporary data, 1927, and they were already teasing out the fact that the whole developing world was ignored when the numbers of 20,000 or 20 million had come out. And this is why we have the numbers that we have now. The developing countries, especially India, Southern and Southeast Asia, were totally ignored in terms of the influenza outbreak of 1918. And the devastating effect of any pandemic will be felt in those places where most of the people of the world live and in close proximity to one another, where transmission will be encouraged. Okay, and the famous W-shaped curve. This is 1918 in the blue, going up in young adults and allegedly going up in elderly as well. But if you look at some of these are data that were teased out with the concept that 1918, they had annualized the data. There was a previous first quarter wave, which was regular seasonal influenza, and a fourth quarter wave, which was the pandemic. And here you see sparing of older individuals, not sparing of young children. Yet this is a constant. In every pandemic we have, young children are at high risk, and we keep forgetting about that as well. Now we have oseltamivir licensed down to two weeks of age, and that was the reason it was done, that these studies had to, the licensure had to be carried out. But, and this is looking at it on a more recent basis, but if you go back and look at contemporary literature coming from the period, you will notice the sparing of older individuals here using life insurance data, and here from the famous Philadelphia outbreak, where the death rate was exceedingly high over a 2-week period after a Liberty Bond march, and there are all sorts of assumptions that are being made or have been made from this, but again, sparing of older individuals. Now, this is very interesting because now there are a group of virologists who are looking at this and saying, well, there was sensitization of the population from the 1889 to 1892 outbreak, and maybe this was responsible with cytokine storm or whatever for what was seen in young adults in 1918. So we're learning new things even from some of the old data. And again, I'll go through this very quickly. With just trains and trains not being allowed to stop in some places, the pandemic wave was very rapid. And surge capacity, you read in the literature the myth that they dropped dead in 2 days or something like that. Not at all. And they filled up hospitals. And this affects, this really is important in terms of any surge capacity. And it was very clear that pregnant women were at particular risk. We had to rediscover this in the most recent pandemic. 1957. Okay. Pandemics occur any time that probably schools are open. And this one came to the US and from Asia, and the first peaked in October, November, and then a small peak later on. And the schools were increasingly very important, and this shows even in August, if the schools are open, you're going to have major outbreaks in the schools. And I remember in 2009 being in an FDA panel where they were assuming that it would be winter before the vaccine needed to be available, well, the vaccine that wasn't available for the spring wave. And a number of us were shouting, don't assume that. Schools open, pandemic resumes. And this is where the classic pattern of morbidity and mortality were developed. And the vaccine was available, but it was available late, and they had to tinker with the formulation, which is another reason why we need vaccines, universal or next generation vaccines, as Rick has pointed out. And this is another observation which is being rediscovered. There was a VA hospital in California, and they showed that with UV lights, they could reduce the occurrence of the outbreak. And here now we're becoming more aware that there is some degree of airborne transmission. And the Institute of Medicine in 2009 was asked to say that masks, certain kinds of masks were not necessary, and couldn't really say that based on the evidence that was presented, even though none were available, which again shows the importance of some of these issues. 68. This was Hong Kong, and again, the outbreak went through very rapidly. China was closed still in this time, and that's why this was called Hong Kong influenza. And then in the US, it occurred during the standard influenza season, an early influenza season around Christmas, with Hawaii and Alaska as outliers in terms of when the peak occurred. But there was also a theory that the old pandemic, the old seasonal virus gets overwhelmed by antibody, and outbreaks go down, and then there's a pandemic. In 1968, the previous epidemic was almost as severe in some places as the following pandemic. Don't forget about seasonal influenza. It kills more over the years than pandemic influenza. And there was relative sparing in the UK and other places during that pandemic. 68, 69 was not the peak. The next year was the peak in England and Wales and other countries in Europe. And these are studies we did on neuraminidase, which again now is the one of the low-hanging fruits for work on next generation vaccines. And this and other approaches were those that were clear even in those days, except the technology didn't exist. The technology does now exist. And now we can exploit the technology to enrich our vaccines quickly with neuraminidase. 76, and this was with Harvey Feinberg in the room and others who remember 1976. This again involved influenza because everybody was ready for swine influenza, and the program was going forward, and Legionnaire's occurred. Legionnaire's disease occurred in the middle, and this shows the problems of overreacting. In retrospect, you never know. In hindsight, you can say you're overreacting, but if you didn't react and something had happened, what then? So 76 is something that we need to keep in mind. And then in 1997, and then from 2003, the same year as SARS came along, we all were energized. And if anything started things going in the United States about pandemic planning, it was H5N1 and the concern about H5N1. And let's not forget about the pre-pandemic use of pandemic vaccines when you have adjuvants and the rest, and that's an old technology as well, use of adjuvants, which has now been updated. And this is something which was very seriously being considered in terms not of stockpiling, but putting them into arms. And that was the idea in 1976 as well as things went on. Safer to put them in arms than just stockpiling when you don't have the ability to get them into arms if you need the vaccine administered. And then 2009, first time the international health regulations were put into effect. And the emphasis again on phase 4. People forget about phase 4 as the key element because that's where when you switch over to pandemic preparedness, and we've been in sort of a 3 to 4 for a number of years now with all these threats coming out of China and other places in Asia, with avian strains which sort of transmit a little in humans. H5N1 did transmit, but not sustained, and the question is sustained transmission, and we still haven't figured out how we can predict, and we do a lot of molecular work which shows that resistance is possible and transmission is possible, but we still haven't been able to figure out how to predict when transmission is most likely. So we are forced to, until we have a universal vaccine, to prepare every time one of these threats comes along at great labor and at great expense. I'll go through 2009 very quickly because it's familiar, and the 2 waves and the fact that it came back when school opened in the autumn, and the fact that older people were clearly spared, but younger people, and some people said it looked like 1918. Well, a very mini 1918 because some otherwise healthy young adults were singled out for severe reaction cytokines, storm, whatever. It's never really been worked out what the mechanism was, but clearly some were at greater risk. And pregnant women, we had to rediscover this, and the whole program had to be changed in terms of distribution of antivirals. And Native population, First Nations in Canada, very clear susceptibility, for whatever reason, living conditions, nutrition, genetics, all of the above. And this was identified in parallel in other places in the world. Again, something which needs to be kept in mind as we think of distribution of interventions, et cetera. Just a final diversion before we conclude. We have lived with a group out there that has identified any appropriate pandemic planning as a plot, something to market disease, and this is what is identified often as a peer-reviewed article in the British Medical Journal, which is actually an op-ed piece, in which this is an example, if anything, of fake news, to use a common term now, and in which some data were used in order to be able to say that this was a plot going on in order to market especially antivirals and to a lesser extent vaccines. And we had to go and do a meta-analysis of oseltamivir data to show that that a drug which was licensed and worked was as good as the clinical trials showed that it was. So this really creates a lot of heat and unnecessary work trying to counter it, but must be kept in mind as you go forward. It's going to be out there, and we really need to factor this in and counter bad science with good science. So observations, clear virologic definitions. I didn't go into this, but some of my colleagues questioned whether H1N1 2009 was a pandemic because it wasn't a shift with a new subtype coming in. But clearly, pandemics occur by other mechanisms than an avian segment coming into the human population. What's clear is antibody prevalence in the population is important, as is the likelihood for spread and severity. And 1918 up to now has been an outlier. In 1957, a group was sent to South America when the pandemic came there to make sure it wasn't like 1918, because this was the first pandemic after 1918. But thus far, it's an outlier, and the question is, do you prepare for a 1918 or do you prepare for a 1957? And this is an important policy consideration. And 68 was delayed, and we can take lessons from this in terms of our approach to next generation vaccines. But each pandemic has its unique characteristics, and CDC has developed a way to early assess what's going to happen with a pandemic, what populations are going to be affected, and therefore being nimble and able to respond is critical. And continuing with Rick Bright's layered interventions, all modalities of intervention are important. I haven't gone into non-pharmaceutical interventions, which are critical and really do need further evaluation. And having attempted some of them, this is very, very difficult to meet the high scientific standard we always have for these kinds of studies. Thank you very much.